All right, enough of that. What I'm going to do over the next 15 minutes or so, and I don't want to run over because if I run over, I'm to blame, is to talk about MR perfusion and diffusion. Now, Dr. Stambuk from Memorial was supposed to give this talk, and unfortunately she couldn't make it because of family emergency. So I'll be giving this talk. Just by a show of hands, how many people in the audience are familiar with the concept of MR diffusion? Okay, about half. Let's see if I can get this to work. So what I'll do very briefly, excuse me, is talk about MR diffusion. Now, for the neuroradiologist in the audience, we typically use diffusion primarily to look for infarcts. But there is a growing body of literature that's suggestive that MR diffusion can be used to evaluate neoplasms, and especially the predictive role as a potential non-invasive biomarker. So my goal over the next 15 minutes or so is to try to give you a bird's eye view of how diffusion and perfusion can be helpful. Now, this is actually a slide of a rat tumor. Now, my pathologist gave this to me, so I'm taking for him for his word. For all I know, this may be a rat testes, but he tells me that it's actually a glioblastoma that was implanted in a rat. Now, this was on day 0, and what this happens now is that this rat was treated with chemotherapy. And then after day 8, the chemotherapy was stopped and the tumor was left to grow again. The point is here is that if you look at the density of the cellularity, you can see that this is much more denser on day 0 than it compares to day 8. So the issue is here, there's much more fluid or extracellular material after successful treatment than prior to the treatment. And this really forms the basis of MR diffusion. So MR diffusion is a type of MR technique that's readily available on any magnet that's been purchased in the last 10 to 15 years. So what we have here is really nothing special. The concept is this, is that if you look at this diagram on your left, this is solid cellular tumor, and this is what we refer to as ADC, our apparent diffusion coefficient. The concept is, and this is appropriate, getting on a New York subway at rush hour. If you're on a New York subway in rush hour, you're packed tightly, you really can't move. So your mobility, translate that to water mobility, is restricted. Hence, that's the concept of restricted diffusion. But if your tumor now starts to be treated, you can see how there's less cells here, and all of a sudden, there's more space. It's like people getting off the subway. Once people get off the subway, i.e. these cells die, you have a little bit more movement. So your mobility is less restricted. So you have less restriction. And as a result, I'm sorry about that, when you then perform this test or this measurement of ADC, you can see that this curve is shifted to the right. So there actually is more mobility. And finally, if the cells are completely necrosed, then you can see we're moving way, way far to the right, and there's lots of mobility, i.e. you're the only one on the subway at midnight, and then you can take any seat you want. You have a lot of ability to move. So this is the concept of MR diffusion. The more dense the tumor, if you will, the more restriction that you have. But if you have some type of technique where you can successfully monitor cell death, whether it's programmed or not programmed, then you have a way to look histologically to determine whether or not these tumors are being successfully treated. So there's a lot of work that's been done over the last 10 or 15 years looking at this, which is our apparent diffusion coefficient. This measures our restriction. And what has been shown is that squamous cell carcinomas of the head and neck have more restricted diffusion, i.e. much more cellular dense packing than normal muscle. So this was just a regular analysis that compared squamous cell carcinoma with regular muscle tissues, and you can see that there's much more restriction in tumors than compared to normal muscles. We've also looked at this using benign lesions as well, and this is a mass that's involving the carotid space. Notice the anterior displacement of the internal carotid artery. Now, I think those of us in the audience that understand the spaces and know that there's no flow voids will say that this is a schwannoma. But one thing that we have determined using ADC mapping is that we can distinguish between malignant and benign lesions. So with me being as a clinical radiologist on some of these indeterminate masses that we see, we routinely perform MR diffusion because it has helped me on numerous instances trying to distinguish between a benign and a malignant lesion, especially on ones that have a lot of imaging overlap between those two. One thing that we can now do with MR diffusion, and the pathologists have been telling us this for many years, is that tumors, as we'll see later, are not homogeneous. They're heterogeneous. Just like I look in the audience now, I see people of all shapes and sizes, of all nationalities, et cetera. Just like the people in the audience, tumors are heterogeneous as well. And when we start treating tumors, we sometimes default to the fact, well, if we give one type of treatment, the tumors are all going to respond the same, and they're all going to respond, each cell is going to respond the same way. But when we start doing our diffusion analysis, what we see is, yes, indeed, these tumors are different. So in this particular case, the blue means that it's low ADC, and you can see in this lesion right here, this has areas of higher ADC, middle ADC, and lower ADC. So now the diffusion gives us the ability to actually look within the tumor itself. And when we perform our analysis, you can see that this curve is shifted more towards the left, and this is more towards the right. This means that there's more restricted diffusion. Remember that analogy I gave you of being in a subway car with lots of people at rush hour? This is the malignant lesion, and this is the benign lesion. So not only does it tell you which one's malignant and which one's benign, but it also identifies the tumor heterogeneity, the cellular heterogeneity that the pathologists have been talking to about us for many, many years. So far what we've talked about, number one, is talked about diffusion imaging and give you a bird's eye view of the histological basis of diffusion imaging. We then just talked about diffusion imaging in its ability to distinguish between benign and malignant lesions. So for this quaternary oncology conference, we're all really interested in the ability of potentially diffusion-weighted imaging to be a non-invasive tumor biomarker. So what does the current data demonstrate about post-treatment imaging versus recurrent tumor using diffusion imaging? Well, this was a very nice paper that was published from Leuven by our Roberto's and I's good friend Bob Hermans, in which we looked at this lesion, he looked at this lesion right here. This was just an example from his paper demonstrating a piriform sinus carcinoma. This ended up being treated, and we always now have the post-treatment changes, but sometimes it's challenging to determine whether or not this is post-treatment changes or recurrent tumor. When he performed the ADC map, you can see that low ADC is more indicative tumor than high ADC. Remember the restriction? If you can't move, there's not as much restriction, so therefore, when you look at these maps, it becomes very, very dark. So in his paper, what he showed was there was actually a 95% sensitivity for distinguishing benign versus, recurrent versus post-treatment changes. Now, I have to admit, over the last 10 years, and maybe Roberto can comment on it too, I haven't had that much luck. I haven't been able to achieve. Have you been able to achieve 90 or 94? No, 99. It's a very, very high bar. Unfortunately, we haven't been able to replicate this. But having said that, it is beneficial. So this was a patient that was treated with a retromolar trigone carcinoma. This is a non-contrast T1-weighted MR. I'll call your attention to the normal fat within the ramus of the mandible on the right. Notice how the fat is replaced. This is a T1 post-gadolinium image. So the issue now is this post-treatment changes, or is this recurrent tumor? And, you know, I can stare at this all day just based on the standard MR, and I can't really distinguish the two because I've seen radiation changes look exactly the same. But in this particular case, when we looked at our ADC values, we can see it's very low. Now, again, the challenge is once patients gets radiation and chemotherapy, we tend to think, is it one or is it the other? Sometimes we forget that recurrent tumor can occur on the background of very advanced radiation changes. So one thing that these techniques allow us to do is help identify these foci of recurrent tumor on the background of these advanced post-treatment changes. So we always have to remember it's not one or the other. Sometimes they can be intermingled, and this is one of the benefits of MR diffusion. So that was looking at a patient that's being treated, determining whether it's post-treatment changes or whether it's recurrent tumor. The next issue is, can diffusion imaging be used for treatment monitoring? And this really is the holy grail. And I think over the last 5 to 10 years, there is now conclusive evidence showing that the MR imaging findings, or actually imaging findings, can predict changes in response prior to changes in volume. So this was a nice paper published from Penn a few years ago. What this demonstrated was the following. In red right here, these are patients that underwent diffusion imaging pre-treatment and mid-treatment. And in red here and in blue here, this demonstrates the changes in the tumor volume. In red here, these are patients that progressed, and in blue here, these are patients that had no evidence of disease. And this was just measuring volume. What this indicated very nicely, and this was confirmed at our institution as well in a follow-up study, was that there is no early, during treatment, tumor volume or changes in tumor volume is not a reliable method for predicting response. Yet, this was from that same paper, what they found was that changes in ADC performed pre-treatment, during treatment, and immediately after treatment is actually a better predictor of tumor volume. So remember that analogy I gave you about crowded subway cars and also the densely cellular packed tumors that I showed earlier? Those histologic changes that I showed on that first slide are predicted earlier with techniques such as MR diffusion than they are with tumor volume. So right now, I think there's at least consensus amongst our radiation oncology colleagues and amongst radiologists that MR diffusion early on is a better predictor of treatment than changes in tumor volume. This is just another example indicating the tumor heterogeneity. This is a patient with a brain tumor that was treated during treatment, and you can see that the response time varies, or excuse me, how the tumor responds differs from the sampling that you perform. So if I go back and look at it, you can see in this tumor that's been treated, this response is one way, this response is another way, this response is another way, and this response is another way. So again, getting back to that heterogeneity. Well, there's a recent technique, and we published this a few years ago in PNAS, looking at this. These are the functional diffusion maps. And the bottom line is it does the following. You can perform MR pre-treatment and then after treatment. And again, when you actually look in the tumor itself, it gives you this tumor mapping telling you which areas in green have not responded and which areas have responded. So these maps are generated by performing a diffusion scan pre-treatment and mid-treatment and looking for the changes. And what you would like to see is the tumor changing, some type of red or some type of blue. If you see all green like this, this means the bulk of this tumor has not responded. So now not only have we shown that diffusion imaging is a better predictor than volume, but we now have the ability to measure tumor heterogeneity and see how other components of the tumor respond. Now, I have to admit, I was surprised by these results. We published these in Trans-Onc not too long ago. But when we compared the PRM maps with just ADC, just taking a big region of interest, and the tumor volumes, the PRM map actually had the highest sensitivity. So just another ability how diffusion imaging can be used as a non-invasive biomarker. So in the last couple of minutes, what I'm going to do is just spend very, very quickly on MR perfusion. Can you just turn that on real quick for me? Now, hopefully this will work. Hopefully, please. There you go. So what happens with MR perfusion? MR diffusion is not using gadolinium. MR perfusion uses gadolinium. And when you're looking at these vessels, capillaries and other vessels have a normal membrane in which provides the transmission of nutrients in which we live by, whether it's oxygen or other nutrients. You can now measure the ability of gadolinium or other blood particles to transfer out and transfer in. This equilibrium that's formed, or the rate of this transfer, is referred to as K-trans, or a transfer constant. You can use this transfer constant, and that's been used to try to, in this particular case, pre-treatment transfer constant to predict response. So this was a paper, again, that was published out of Penn, 33 patients with head and neck cancer. They all underwent perfusion and diffusion contrast enhanced imaging. They measured the K-trans, and what they found was the following. They actually found that the pre-treatment K-trans was a predictor of response. So when they performed pre-treatment diffusion contrast enhanced imaging and they measured K-trans, they found that tumors that had a higher K-trans pre-treatment were more likely to have a complete response than those tumors that had a partial response. Another example is showing similar data by Mchala et al. Again, they measure K-trans pre-treatment, and they demonstrated a very nice separation of the curve based on pre-treatment K-trans analysis. This study was performed at our institution. This was to look at a transfer contrast, pre and post-treatment. So what we did here is we took a series of patients pre-treatment and performed gadolinium-enhanced MR, diffusion contrast-enhanced imaging. We then measured 2 weeks after radiation therapy, and what we found here was that a decrease in K-trans after 2 weeks indicated a non-responder, whereas if there was an increase in the K-trans, this indicated a responder. So this early data, and this has now been funded by another grant from the NIH, investigating these, tells us that yes, again, diffusion contrast enhanced imaging can be an early predictor of responders versus non-responders. But what I'll do, and I'll end with this slide, is the ultimate challenge, because anytime that we start using imaging to try to predict response, we're always faced with this dilemma. We want to try to determine as early as we can whether or not the patients are responding. So we tend to do a lot of things very, very early on in treatment. In fact, after 2 weeks or 1 cycle, so on and so forth. Or we'll try to do imaging immediately after treatment. But what I'll say is the following, is that the challenge is that as you wait during your treatment, you have this increasing therapeutic effect. And the goals of this imaging is try to perform the imaging at a time that permits sufficient therapeutic effects. And the challenge is that if you image too early, sometimes, and this is my biggest concern, is that when you see these changes in diffusion and perfusion at 1 cycle or 2 cycles immediately after initiation, the challenge that we have is I sometimes worry that we just may be seeing the acute effects of treatment. And that's the biggest challenge that we have, because remember, we're seeing increased therapeutic effect, but in order for the radiation oncologist and the medical oncologist to really make a true judgment, there has to be sufficient therapeutic effect where they feel comfortable that the treatment's working. So if they wish to abandon this and go to a new therapy, they have to be able to justify that the current treatment regimen was sufficient. So my own feeling is moving forward, we scientifically want as many data points as early as we can. But from a clinical aspect, I sometimes wonder if we shouldn't be imaging a little bit later in these patients being treated with non-surgical organ preservation therapy. And there's more data coming out that maybe we should wait maybe halfway, instead of at 7,000 gray, maybe between 3,000 and 4,000 when we actually do this pivot imaging. So in summary, what I've tried to do is talk about MR diffusion and perfusion. I'll go ahead and stop there, and we'll go on to the next conversation. Thank you very much for your attention.